Hello, everyone. This is Dr. Richard Fleming, and today is Saturday, the 2nd of January, 2021. I was planning to hold off a few days to do the next video and give everybody an opportunity to get through the New Year's because I know many of you are spending time with family and friends. But I've seen an awful lot of postings and getting a lot of questions lately about PCR testing and the validity or lack thereof of the test. It's important to realize that PCR test is really a qualitative test. It's a yes no light switch on off moment that really tells us whether you do or don't have, in this case, SARS-CoV-2. But after that question is answered, it really doesn't provide you much useful information. It's not very helpful for determining if you need treatment, and it's not a useful method for determining if your treatment works because at some point in time, you're going to see a change in this when the light switch goes off. But it's not very discriminatory and it's not a quantitative method, and therefore it's not very useful scientifically except to suggest that you're working with the right patients to at least consider whether they need treatment. That being said, the study that we conducted with the 1,800 people, of which 501 ended up in the hospital, all needed to have a positive PCR test to enter the study merely because this was the study that so many people are using, and it provided us with information that the patient did in fact have this virus in their nose or their throat. And if, in fact, they then became symptomatic, this would be the probable cause for them being ill and the need for treatment. After we get through those initial hurdles of deciding who does and doesn't come into a study, we really need a method of measuring. And as I've talked about before, FMTVDM, the patented test that I have that measures changes in tissue blood flow and regional metabolism, was what was used to quantitatively determine the extent and severity of the infection in these people, as well as the severity and infection of the inflammothrombotic response, which is what kills people with the inflammation and swelling or the blood clotting. This is an extremely useful tool when geared appropriately. It can be used for heart disease or cancer or infections, in this case, as it was for SARS-CoV-2. It's not my intent at this point in time to be trying to promote that test because I simply am not going to take the time to try to educate every one of the hospital systems on how to use this test for SARS-CoV-2 or COVID-19 patients. That was never the intent of this study. The intent of this study was to use it as a quantitative method. And the setup of FMTVDM is dependent upon what types of cameras you're using, what types of isotopes you're using, what types of enhancing drug agents you're using, and what you're looking for, which all put together tells you how you need to look at calibrating the camera so it's accurate, and then to conducting the studies. With the information that we obtained, it's not important that we really have FMTVDM up and running for everybody at this point in time. It will be useful for heart disease and cancer and any future infections, but the goal is to get the treatment out there for people so that we can quit seeing so many people end up in the hospital and so many people dying. That is, after all, the importance of medical treatment of patients. What I want to do is share a few slides with you from a presentation that I will be giving next year. These are only 3 of those slides, and it answers a little bit of the information about FMTVDM and this study. So with that, let me share the screen. And I will show you these 3 slides. The first one explains that we used 3 measures of quantification or measurement in the study. One was FMTVDM. And then we also used 2 blood tests, one called Ferritin and one called Interleukin-6, which were measures of the inflammation associated with the infection itself. The definition of success um, depended upon the improvement of FMTVDM, ferritin, and interleukin 6. And the definition of failure would be these getting worse or the patient dying. The values for FMTVDM that we were looking for in the end that measured clinical success and return to normal would be an FMTVDM value of less than 150. And you can see that on this curve here. This is from research that I've published previously looking at large numbers of individuals and looking at changes in tissue in the dead or metabolically inert normal area. And then as tissue becomes more metabolically active and has more blood flow, we see tissue transition from inflammation and infection to later stages to, if the process continues, we see even greater numbers with cancers as they differentiate. And this sigmoid curve, while it's something that was demonstrated with FMTVDM, is consistent with what Gompers and Laird in their previous models from 50 to 75 years ago had proposed would in fact occur with changes in tissue. So very consistent with what these scientists had previously postulated. This is an example of an FMTVDM study. You can see the liver over here. This is the heart. Stomach in here. This is the right lung field, left lung field, and this is the mediastinum. That includes the thymus gland, which is significant for T cell activity. And this is just one example of an image taken from somebody in this study. As I said, we compared FMTVDM to ferritin and interleukin-6. And if we look at the results over the course of the study as people transition from day 0, entry into the hospital, to every 3 days, from there, 0 is entry, day 1 is actually day 1 in the hospital. You can see that ferritin levels as a blood test, which are in nanograms per ml, and interleukin-6 levels here, which are in picograms per ml, and then FMTVDM maximum count activity units are here. And so these simply lay out not because of severity differences, but because of what is normal in these ranges. And you can see that as one changed, the others changed, although there was a slight lag time between what happened at the tissue level and what happened in the expression of ferritin and interleukin-6. And you can see the correlations or the relationships between these. The greatest, strongest relationship between FMTVDM and a blood test was between FMTVDM and interleukin-6, that's 0.72, 0.72. Ferritin just a little bit less associated with that because it did take ferritin a little bit longer to transition down. So there was a several day lag time in ferritin, a day or two for interleukin-6 following the transitional changes of FMTVDM. And then I want to end with one last slide here showing an actual patient. This was, again, the definitions here, as I mentioned earlier, successful treatment was defined as FMTVM of more than or equal to a 25 MCA FMTVDM drop. If it was 25 or more, it was considered successful. If it went up by 25 or more, it was considered a failure. In between 0 and 25 change either way was deemed as not a significant change. It might represent some benefit, which meant that a new drug was randomly added to the regimen. Ferritin levels considered normal if they're less than 270 nanograms per ml for men. It's a different value for women, 160 nanograms per ml for women, because they tend to have a lower ferritin level to begin with. And the interleukin-6 levels, normal range for both men and women, are less than 5 picograms per ml. Already went through that. This is the same curve that you saw before. Here was an example of a woman, patient 3/1, who entered phase 1 of the study, where treatments are assigned one individually and then added sequentially over every 3 days, depending upon whether treatment was considered successful or not. This is her initial entry. day one of the hospital. Her MCA value from FMTVDM was 195. That's elevated. You can see it's elevated in this category range of inflammation and infection, ferritin 302 and interleukin 645. This treatment one is the combination of hydroxychloroquine and azithromycin. Now, failed only in the sense that the patient ended up being admitted to the hospital. It's very much likely that there was some benefit to this treatment of hydroxychloroquine and azithromycin, that the patient might have ended up being worse. It's impossible to tell without actually having these tests at the beginning of the outpatient setting, but that was really well beyond the scope of the study of being able to study everybody as an outpatient, not only from doing FMTVDM studies, but from getting ferritin and interleukin-6 levels. So this is upon entry to the hospital. This person ended up receiving treatment arm 8, which was methylprednisolone and very specific doses. And 3 days later, day 1 to day 4, repeat study. You can see that the right lung field here was the one that had the greatest activity. Again, I caution you, this is what you're doing is you're looking at this visually. That's a qualitative image, and people see what they want to see in qualitative images. You cannot use these to truly determine successful treatment outcomes or even the presence or absence of disease, because again, multiple studies have been done comparing images that board certified physicians in whatever the field of specialty see in these images, and people see what they want to see. They even miss gross abnormalities that are put on the images to see if it will be caught. More than 3/4 of the time, board certified physicians will miss things that are put on just to see if they see anything that's abnormal when it clearly is. And routinely the general public sees none of it based upon the studies that have been published. So if you're looking at this visually and thinking, aha, you know what it is, aha, you don't. You just think you do. And so when we compare this, the measurements are critical. The cameras have to be calibrated knowing when we're going to image and what we're imaging with isotope Y as an enhancing agent and what we're looking for in cameras. And so for that reason, I'm not going to go through a concerted effort at this point in time to try to teach the medical community how to do FMTVDM to begin with. It's patented. It takes a while to learn, like any procedure. And right now, I think our backs are up against a wall. Our obligation are to get the treatments out there for people, not to license my patent. When and where we'll do that later on is that's a conversation for the future. However, this area, even while it looks better than that, if you're just looking at blue and you're looking at this speckled image, you have to quit visually thinking you're better than everybody else on the planet to read these things, because people cannot. And that's why it needs to be a quantitative method. And that's what FMTVDM is. So the count went from 195 to 170, which is exactly 25. So it's not less than 150 where we'd like to see it to bring it into the normal range, but it's headed the right direction and deserves to continue being treated. You'll see the ferritin level, this is a woman, is 195. So again, it's above the normal range for women, as is the 12 interleukin-6 for anybody. However, everything is moving that direction, and that is how we know with this study which drugs worked and which ones did not. PCR is a heck of a tool to actually get you in the door to be part of the study. You got admitted to the hospital not because of a positive PCR, but because of a positive PCR followed by a physician looking at you and saying, you are symptomatic to the point that we need to hospitalize you for further monitoring and treatment. And monitoring doesn't save lives, treatment does. And that's what they got by being part of the study. So hopefully that clarifies some of the information about PCR and the difference between a qualitative and a quantitative test and imaging. Happy New Year.